share. You have to stop screen share.
Unless you're making a presentation.
No,
not at all, not at all. Give me a second.
recording करने का है कुछ?
I need my daughters for this nonsense.
Oh.
Go to the top of the screen and you'll find stop screen share.
Okay, Ji.
Top right, top.
Ah, that's right.
Yeah, better.
Very good.
Hello, Vinesh.
I see a lot of
Gaurav, come in. Yeah. Hi.
Hi,
Dakshita. Hi, Dakshita.
Hello.
Hi. Madhu.
Namaste, Mama ji.
Madhu, I scored 81 at
Tuesday. Namaste, Dr. Chacha ji.
Yeah.
That is amazing.
All the youngsters put on your videos so that we know that you're there and that you don't leave.
Ranu
Put on
Chacha,
your
Gen
cameras.
1.
We have a Gen 1 also on the.
Giant and Anand.
Hi, Anand.
Hello.
Hi, Madhu.
Hi, who's
Hi,
that?
Neeraj. Hi.
Hello, hello.
Wow.
Hi, Neeraj.
only OG
Everybody
around.
put on your cameras so that we can see you.
Arjun Barka, Madhu Chachi wants to see you. Yeah.
Yes. Yes. Very, very visible.
Hi,
Bantu.
Hi, Barka. Hi, everyone. Is that the COVID look?
मेरे वाले क्लिक कर लीजिए.
Hello, Dakshita.
So listen, should we wait for a couple of minutes or should we start?
We should start. We're already 2 minutes over, 3 minutes over.
I know. But you know. Okay, I think
Ranu, request everybody to switch their.
I will. Let everybody.
So Ranu, can I make a suggestion? Hello, Ranu. Can I make a suggestion?
Yes, of course.
I think when somebody, I think everybody should unmute themselves, to mute themselves. And if anyone wants to ask a question, they should raise their hand and put the microphone on.
Right. I was going to say that anyway. Hi. Okay, so I think let's start, okay?
Yeah, sure.
Would everybody please mute their audio? Okay. And we start recording. So good evening, good afternoon, and good morning, family. Welcome to the second session of the Family Discussion Group. Before I, just hang on, this is nonsense. Yeah. Sorry about that. Okay. Before I talk about today's session, I have to say that the response to the last session was on the new education policy, both in terms and in terms of the comments that followed afterwards, the reaction. One family group, and I won't take their name, actually said that this was the best webinar that they have been to during the pandemic. And so it was a great start. This was ably led by Namita, and valuable contributions were from Veena Jiji, Kirti, and Rashmi. Thank you all.
Namita left.
It was a great inauguration by 2 speakers each from Gen 2 and from Gen 3.
We are facing bandwidth problems.
Would everybody put yourself on mute, please? Yeah. In today's session, we'll have 4 speakers. There will be 3 from Gen.
Put on the Geo.
1 from Gen 4. But before I introduce the speakers, let me just give a few guidelines, please.
Should I put on the Geo?
She had the bell, by the way. And also she will collate the questions that are asked. She'll ring the bell after 9 minutes into each speaker's talk. Planned for 10 minutes. Yeah, there's the bell. This is necessary to stay within the 75 minutes that we planned for today's session. This will give all of us enough time to have a free-flowing discussion after the speakers have concluded the opening talks. A small request, please. After the formal start of the session, which is now, please keep yourself on mute throughout the session. Givi will be the moderator and will invite questions. Some of these have already been submitted by you, and part of a question has circulated earlier. At the end of the session, please stay on because I'm going to announce the next question after this one. Okay? So now with the introductions. The first person to come on will be Dr. Givi Gaurav. He's a urologist and he works at the Tata Apollo Hospital in Jamshedpur. He's a COVID warrior. The only other description he's actually given me is that he's a reader and a poet. Okay. By the way, Givi is on the highway from Jamshedpur to Kolkata on some personal matter, so he's going to be operating from his phone. If there is a signal, otherwise we will restructure the meeting a little bit. The second speaker will be Professor Dr. Shinjini Bhatnagar, Professor of Eminence at the Translational Health Science and Technology Institute, Government of India. She's a pediatrician with 3 decades of research on maternal and child health. She was formerly at AIIMS and she's continuing this research work. By the way, Shinjini is one of the is the busiest person I know. She works all the time. She's one of the most helpful people as well, as far as expert advice is concerned. The third speaker will be Garima Bhatnagar, 1994 IPS batch. He's the Chief of Mission Management and Support Section of the Police Division of Department of Peacekeeping Operations in New York City. She is in charge of the management of 16 UN missions who are involved in COVID response all over the world. He's recently been promoted to Additional Director General of Police. Way to go, Garima. Congratulations from all of us. Yes. And the last person to speak will be one of the newest members of our family, Dr. Radhika Dua. She works at the King's College Hospital. She is, and I have to be careful of how these words are a little difficult. She's an oral and maxillofacial surgeon. During the UK lockdown, she worked in the COVID and provided surgical tracheostomies for COVID patients. I think she will explain what all that means. And she is a writer on COVID also in London. So with this introduction, now Radhika is being called away for an emergency with a patient. And so she will try and join in for about 15 minutes during the session and we'll allow her to come in at whatever time she comes in. With this brief introduction, it's over to you, Givi. Givi, please.
Right. Thank you so much, Ranu Mama. And I'm sorry for the video quality. I just wanted to show that I am on the road, so there's nothing much to see. And I'm actually impressed the way you got that surgical tracheostomy right. I mean, I didn't get it right even after 2 or 3 years of being in MBBS. But you got it right in the first time itself. Thank you so much for that introduction. And since I'm on the road, I will not waste too much of time in the introduction part, etc. We are very thankful to Ranu Mama for having this important session on COVID. The whole world is going through this. So I would probably, before I lose any connectivity, I think let me get to the crux of it. We had conducted a survey and all of you have very graciously answered. And there have been an amazing amount of responses. So I think before starting off, I think I will use it as a template for my 10 minutes. And maybe if I can request Suvira Bhabi to start showing the first question. The first question actually was a survey that we took upon how, what is, hello? So is everybody able to see the screen?
Yes.
Yeah.
So, Bhabi, can we enlarge the size?
Gaurav, can I come in here, please? It'll be nice if people who are not talking to switch their videos off, especially if you're on the road, the bandwidth will be better.
Okay, my video was off. I don't know how it got turned on.
No,
Sorry.
no, not you.
So,
I'm saying the people who are not speaking, because then it'll be
okay.
good for, yeah.
So anyway, my video is, I mean, can hardly see anything. But so the first question that was sent as a survey was, I feel that this pandemic is going to end. And there is a whopping number of people in our group, around 40 responses. And if you look at the responses, almost 40 to 50% think that this pandemic is going to end by either mid 2021 or the end of 2021. Now, as a person who has been involved with the COVID scheme, I would like to put my 2 bits of thought over here that this mid 2021 or end of 2021, both are very, very optimistic uh, estimates. The end of the pandemic depends on two major things. One is that we somehow gain a herd immunity, which again is a concept which is very difficult to understand and even more difficult to probably for that concept to get into to see it into practice. Please, of the people get infected, get cured, and thereby we as a species, so we as a species will become immune to this disease. If that is our definition of a pandemic, then I don't think 2021 is going to be the end of it. The pandemic as a disease will probably be here with us for another 2-3 years. What we need to know is whether we can live with it, because there are pandemics we are already living with. One of the biggest pandemics that we are still living with is that of HIV/AIDS. We don't see it that often because that pandemic has also caused us to do some changes in the way we do our business, especially in the medicine side. So earlier, we used to be very cavalier about blood transfusions, etc. But now all blood products, blood transfusions are actually monitored and they are seen whether they have any HIV virus in them. We have started using a lot of shields when we know that there is somebody who's HIV infected. The medical part of it has come a long way, wherein the medicines have started becoming more effective, but we still don't have a vaccine for that, and we have learned to live around it. COVID will probably be similar, because the main problem with it is the infectivity, the sheer rate of infectivity being too high, and the route of spread is actually something as simple as talking to a person who's infected, who may be an asymptomatic carrier. So what we need to do is to learn to live with it. And that is where our second question comes in, that one of the ways to live with escape it, the main way to escape it is to not get infected. Now, not getting infected is wearing a mask. As we can see, a majority of the people have said that it's just an inconvenience. I mean, there are 3 guys who think it hides their. I mean, that's very sweet of them to have taken that option. It was just to put a smile on your faces. But a huge majority, it actually does not hurt their ears. It does not hurt their. It does not suffocate them. So it is basically an inconvenience. Now, this inconvenience is nothing compared to an inconvenience on the ground that you are going to face if you have to ever go through the rigmarole of going through a testing, or God forbid, if you're positive, getting a bed in a hospital. So whenever you feel that, this mask is an inconvenience, please, in your thought, just put it over there that this is nothing compared to the inconvenience that I'm going to feel in case I'm going for either a testing or an admission. So yes, the mask is an inconvenience, but please use it as much as you can. Use it with as much, on as many occasions as you can. Obviously, there are some precautions to it which are easily available. Don't use it while don't use it while exercising. Don't use it while you are alone by yourself. But otherwise, always and always use a mask. Now, the next thing that I'm often asked is, if I've met someone who has been detected to be positive, what do I do then? Now, in that, as we can see in our own survey, that a majority of people would actually wait for 14 days, see if they ever become symptomatic, and go for testing. Now, this is something which is by the, we have to understand that this disease is the evidence is changing as we talk. So earlier, while there were thoughts that you should get tested as often as possible and as quickly as possible, now those things are changing. So yes, I agree with the majority of the people that you can wait for 14 days, but the middle part is much. At the first instant, whenever it is possible for you, at least get some kind of a test to know whether you're positive or not. That helps in a lot of other things also. And the more we are going to get tested, the more people are going to get discovered. So we will probably come to know that we are in community transmission. Community transmission, as we have all seen, is basically that you cannot trace, going back, you cannot trace the positive contact as the source. So once, it has become so muddled that you cannot take it to one person. That is what is community transmission. And we have been, whatever the people may say, whatever the papers may say, we have been in community transmission for a while now. And in that, a lot of people have agreed that we have failed as a community. Well, I don't know whether that is a failure, because if you look at the population of UK, it's around 6.6 crores. The population of UP, Uttar Pradesh, is 20.2 crores. So in a country which is this densely populated, we were almost destined to fail. It is not so much a problem of the people being careless, but it's just a socio-cultural situation that we have as far as India is concerned. So yes, community transmission is happening, and there's precious little that we could have done to prevent it. But yes, there were steps, as Shinjini Mami and Garima Jiji and Radhika hopefully will talk about. There were steps which we could have taken. Now, coming to my next issue, which I thought most people would be talking about, is have you lived through such a catastrophe? People are here who probably have lived through many more catastrophes. There are a lot of us who have not. But the point that I wanted to make is that things probably went back to normal as if after a war, after the SARS pandemic. But this way of change of life is probably here to stay for a longish time. It will not be that we will stop wearing masks, we'll stop the social distancing in a hurry. It's going to be here for a while. And apart from that, social distancing, yes, it is absolutely required. I will think blue rather than the green portion that is there. Please do not take it in any likeness. This is definitely required. India is doing much better. This is something which is a lot of debate. I talk more about it. And yes, last scene, I think a vaccine is something, it's just one of the treatments that we will, but it will not be a panacea. A lot of people have asked whether it will be effective, whether it will actually work. But I wanted to start my talk with one question which was given, and that will answer here, that do we really know what's happening? Do we actually have a clue? Well, the answer is no, we don't have a lot of clue, and we don't really know what's happening, but we are learning as we speak. And one of the biggest things that we are learning as we speak is about the testing. And I would request Shinjini Mami to now take over and take us through the testing part and the biology that is behind this. Have your session, please.
Thank you. That was wonderful.
Thank you, Givi. So I think at the outset, let me first clarify, I'm not a COVID expert. Can you hear me? Yeah. So firstly, I'm not a COVID expert. I'm a pediatrician who has some experience with child health research. I tumbled into COVID because of the need of the hour, just like my other members in the family here who are talking today. I've been asked to speak about diagnostics and vaccines, and I think some of the and I'm going to take about 10 minutes. I'm happy to answer more questions because this really is a concern that many of us have. And some of my relevant points, and I'm going to put them just down as points rather than a narrative, come from the work that we are doing on COVID, which is a big Government of India initiative where we are following a large cohort of COVID positive patients. We have almost now 3,000 COVID positive patients who we are following from the time they get admitted to the hospital or are tested positive over a period of almost a year. And we'll follow them up. We will follow them for a year, and trying to understand what's happening to the disease, looking at their biological samples, looking at their clinical data, largely to create a biorepository which can help in developing diagnostics and vaccines. So I think I'll switch the video off. Okay, so let me first begin with what Givi said. How are you sure you have SARS-CoV-2 infection? I think most of you know that the gold standard test that the government is using, not only here, but globally, is the RT-PCR test, which is gold standard because you're actually picking up the virus from where the virus will be lodging, like the nasopharyngeal area and the nose. And this is as you know, is being performed through swabs and nasopharyngeal swabs, but you can also pick it up in the saliva, in the stool, as well as in the bronchial lavage. But those are very difficult to get, and so one uses what is easy to get. There are a lot of gene targets that of the virus, which this test aims to pick up. And when we say we have a positive test, there are actually 4 gene targets. I won't go into the details, but if the test picks up at least 2 of these gene targets, then it's a positive test. Now, I don't know if there's anyone who's gone through COVID here or has had a COVID testing, but there's something which on your report, if you've tested positive, will be given as a CT titer. Now, just to explain that, and this is important, it's going to come up more and more as we go into the pandemic. This is a cycle threshold that the test has to go on, the number of cycles the test will do to be able to pick up that virus. So it's inversely proportional to the amount of virus you may have. If it is a high titer, you will have a low virus load. So a test of less than 40 is considered positive. Now, having said that, it doesn't correlate. If you have a low viral load, we still don't know whether you're going to have asymptomatic infection, symptomatic infection, or you'll end up in the ICU. Unfortunately, that evidence is still not available. The other thing is, when should you get this test done? And Givi said that people have said they'd like to quarantine themselves for 14 days. I think one of the biggest problems that we've had is that people have shied away from testing. Testing is absolutely critical. You have to test because not only are you getting to know what you have, you're also protecting people around you. If you don't know that, you're not going to be able to protect the people around you. And therefore, the testing, so the virus gene is visible on day 1 of your symptoms. Day 1 of the symptoms, it starts to amplify, and by 1 week, it's at its peak, and then it starts to decay. So by 3 weeks, it would have decayed. So the idea is to test maybe not on the first day of the symptom, but at least when it's peaking about 4 to 5 days of your symptom. Now, I'll come to the asymptomatic shedders a little later. And the next thing is, so if you have a test, are you sure it is COVID? Yes. This is a super specific test. There'll only be a 1% chance that you're a false positive, if at all. Otherwise, but on the other hand, if you test negative, you may still be positive. So it's very important to remember that if you are symptomatic and you have characteristic symptoms, then there is a 30% chance that you may actually be negative because of the test. Then a positive PCR, this positive test, the other thing that we must know, that it really doesn't tell you whether it's an active virus or a dead virus. So when you do the test, you just know the presence of the virus. It is not possible for us to know whether the virus is just colonizing, it's active, or it's dead. The second question that you may want to know is, when should you get yourself retested? You've had the infection, you've gone through it, when should you get retested? And again, because it starts decaying from 10 days onwards, you don't know when is the right time for you to get tested, because you may test positive even if you're not having a viable virus. So to be able to curtail that uncertainty, now it's what is called is a symptom-based retesting, which means that if you're free of symptoms for 3 days, then you are actually negative, or at least 10 days after you started to be symptomatic. Now the question that may be asked is that what happens to asymptomatic shedders? I really don't know what happens to asymptomatic shedders. We don't know. If you test positive, if we test positive as an asymptomatic shedder, we don't know when the infection started. We don't know when the infection is going to end. And do not believe when they say that asymptomatic shedding is not contagious. It is contagious, and that is one of the reasons why India is where it is today. Then, when should the contacts be tested? Like, you've had a COVID positive patient in the house. When should the family members be testing for COVID? The ideal time would be 7 to 8 days. Is that the bell, Suvira? Okay, because I still have the vaccines to go. Anyway.
No, that wasn't me. That was probably a car horn from Givi's car.
Okay, okay.
No, Givi's on mute.
Okay, sorry. So the contact should be tested a week after the index case has tested positive. So if there's an index case, then a week after the last contact with that index case should be when you should test. Otherwise, you can be falsely negative. You may not be harboring the virus, it still may not be there, and the test may not be able to pick up that very low titer in your. The other problem that we've had, and I don't want to dwell too much onto, is this antigen testing that is happening all over India. I don't know, globally also they're doing it. Antigen testing for personalized testing is not good because it's missing 50% of cases. So if you do an antigen testing, if you go and you please ask for a RT-PCR and not a rapid antigen test, because there's a 50% chance that you may test negative when you are actually positive. If you're negative, then you have to go in for a RT-PCR. And therefore, it's always better. I mean, antigen detection test is a public health issue. I can talk about it in the question answers. But for personalized testing, if I'm asked what is the best test, it would be the RT-PCR. Then the other form of testing, which is an indirect measure of knowing whether you have had the infection, which all of you have been hearing about, is the antibody tests. There are different types of antibodies. Again, not going into details, A, G, M. M is the first one, then A, then G. You know, surprisingly in this disease, unlike other viral diseases, we are hardly seeing any IgM. Don't know why. IgG comes up around anytime after 3 weeks, may peak at 7 weeks, and A comes up in between. Now, what does it mean? It means if you have it, it's a 95% definite that you have actually had the infection. Does it protect you? We don't know. The only way of knowing is to do more testing and seeing if these antibodies are actually neutralizing the virus, which is still an experimental stage. So having antibodies does not tell you that you're protected from reinfection. And therefore you have to continue to use the same precautionary measures as you've been doing if you've not had COVID. So I know it's a real painful thing. You go through COVID, you've had it, and then you're told, sorry, no antibodies, like it's happened in our family, but it actually happens. But the interesting thing that we are seeing with this virus is that there's another kind of immunity, which is the cellular immunity. So the antibodies is coming up in the blood, in the serum, and that's why these plasma donors are being sought after. But let me tell you, plasma donation has not worked out as well as we thought it would. So then you have the cellular immune responses, which are again T cells, B cells. These cells help the antibodies to also develop, directly kill the virus. This is very interestingly, this is what is being seen with this virus. Again, experimental stage. We are, at least in India, many of us are trying to understand what happens to these immune responses. Currently, there are no tests in the market which can tell you your T cell responses, but this could be the answer to the immune system or the immune response to this virus. But again, very experimental at this stage. So then it brings me to the last bit of my thing, is are vaccines the answer? And I know everybody is excited, waiting for it, and one should be optimistic. Why not? But certainly it's not around the corner. And I'll tell you, I'll first give you the depressing side of it, and then maybe some bits of the happy side of it. So SARS-CoV, so we've not been able to get vaccines for the other coronavirus, like the SARS-CoV-2 and the MERS pandemics. Hi, Radhika, do you want to join now? I have another 5 minutes.
I'm so sorry. It's a bit crazy at work. I'm just in my hospital, as you can see.
So why don't you go ahead and I'll come in after you.
Okay. I mean,
Yeah.
mine was, I'll keep mine very brief because I know that lots of people are talking and have lots of interesting things to say. I thought I'd just talk about the sort of the UK experience and also about my experience with COVID, and I worked on ITU, so some time ago now. So I was deployed in April and May, and I think India is coming a little bit later in COVID than we have here. So we've kind of gone through it, and I think you guys are sort of slowly following the same thing. But hopefully, you know, things are getting a lot better. In my hospital, we only have 3 ITU COVID patients now, and I think less than 20 people in the hospital, and we had the most in the UK at one point. So it's quite a dramatic change. And some of my experiences, and I was very fortunate. So working in ITU, I saw sort of patients who had the privilege of having round-the-clock care, 1-to-1 nursing, or 2-to-1 nursing sometimes, which was not normal for ITU. Usually you have 1 nurse to one patient, but because of shortage of staff, we had 2-to-1, which is still amazing compared to wards, which I'd imagine in many other places it's maybe 1 or 2 nurses to 20 patients. So much easier, and then lots of excellent care. So most of these patients were intubated, and they were intubated for at least 30 to 40 days, actually, we found on average. People, once they were intubated, stayed intubated for some time. And that's not necessarily because of complications, but actually the pathology of their disease, which I'd imagine someone else has gone through a little bit about, and the patterns of disease that these patients just took a long time to recover. And some of the issues we had here, which perhaps you are also seeing in India and in the States and other parts of the world is drug shortages. So we had a massive problem with shortages of, well, shortages of many things, but anesthetic drugs, so things like propofol and fentanyl, which is an opioid, so typically things that are used to put people to sleep. And these are sort of considered first-line anesthetic drugs in today's day and age, but we moved on to other medications which we don't use as commonly, including midazolam, ketamine, which leave patients with bigger hangovers and have their own complications as well. So we had sort of propofol and fentanyl sparing regimens, and actually our hospital was keeping track because we were running out of all these drugs, or even just using morphine. And then we also had shortage of PPE, which I'm sure is the same everywhere. And certainly we had a different delivery of some sort of PPE. I had a hazmat suit from Taiwan one week, and then which had and another one that was from China. Some were waterproof, some were not. They were all very hot and very sweaty, and masks that changed every week. So I had sort of lines down my face like you see on the TV shows and also on the news. So they didn't necessarily fit very well either. So it was very interesting. And the other thing we realized is as we were treating the patients, people really didn't know at the beginning how to manage COVID. And the information from anywhere in the world, I think there was a lot of hearsay, and a lot of things are not evidence-based necessarily, but more politically pressurized. I think hydroxychloroquine is a very good example, which has been sort of celebrated quite a lot, and has a lot of people have sort of tried to stockpile as well, which has no evidence base. And I'd imagine, something a lot of people would like to consider, but there isn't really much evidence base for any medication really per se. There's some for dexamethasone, but again, very small, lots of patients, and very hard to do sort of a proper trial on unwell COVID patients. We were doing multiple trials, but I think actually the numbers overall, we will see what will happen. And same with remdesivir, it's actually limited evidence base for that, but who knows, some of these things will be good, but it's very interesting what will happen. And did I want to say anything else? And then the other thing I wanted to talk about was the hypercoagulability. So actually lots of the ICU patients, what we found is that, sorry, I'm on call at the same time, they had high risk of clots, so either in the leg or the lung, so pulmonary embolism and DVT. So we were giving patients very high doses of heparin, either a low molecular weight or unfractionated, and they required doses that were somewhat like if they already had the clot rather than not. And then they were also, so that was a problem, and many of them were developing it, which worsened, particularly their pulmonary function, worsened it further, so along with COVID pneumonitis that they already had. And then the other thing I was involved in, sorry, it's not as ordered as I wanted to say all of this, but I'm trying to get through it before my phone goes off again and I have to run off, was that I was involved in the surgical tracheostomies for some of these patients. So in part of having fentanyl and sedation sparing, if someone has a tube in their mouth, if they're intubated, our gag reflexes when we're awake would not allow us to have a tube down our throats. It's hugely intolerable. And the alternative was was to provide a tracheostomy, which is Ankur is a really good, it has really understood this really well, but it's a hole made through the neck here, and you can do it either with a technique with a guide wire and tunneling things over, called the Seldinger technique, which a physician can do, or also a surgical method, which is what I was involved in, which is making a cut in the neck and putting one in theatre, which is a highly risky procedure in COVID because it's the release of a lot of aerosol, so high risk to the operators and to the theatre staff. But it meant that patients could be taken off sedation if they were able to. They could wake up. Many of them didn't actually, despite that, but it was a way of helping also preserve anesthetic drugs actually. And we had quite some interesting things with that. So patients would get them usually sort of 10 days to 2 weeks down the line after they'd been intubated on ITU. And then they would, once they had them in, they would take a long time to be, to have their tracheostomy removed. So that's called decannulated. But it was helpful in that providing care, so oral care to patients, and also if they were able to wake up or if their families saw them, because we did FaceTime, basically. We had doctors who weren't so comfortable with being physicians, so people who were perhaps consultants in something like neurophysiology or something that isn't really clinical. Their role was to use iPads to have families speak to or see their unwell family member to minimize the number of people coming in. And actually for families there was that was quite reassuring. Actually seeing them with a tracheostomy rather than tubes and things covering the mouth made them much more human and normalized. So it was a very interesting experience. But I think I've rambled a bit, and I think that's all I'm going to say, because I've given you a lot of information and probably quite garbled. Is there anything anyone wanted to ask before I ran off again?
Radhika, thank you so much. We will now move on to Shinjini, and we will send you the questions, and you very grateful that you did what you did right now in the middle of your emergency.
So
thank you so
I couldn't
much.
stay longer.
Okay.
All right. Take care, everybody.
Bye, Radhika. Thank you.
Bye. Bye.
Okay, so because we've been told to stick to time, and I'm sure there are a lot of questions I saw in the chat box. I could some of the questions related to the diagnostic tests that I've spoken about, and I'm happy to take them after I've finished. Surira, is that the way you want to do it? I can just quickly talk about the vaccines, because that's another area which people will have a lot of questions.
We'll take the question after Garima finishes.
Okay, great. So just want to tell you, the vaccines are not around the corner. The negatives are that we don't have a licensed vaccine for SARS-CoV-1 and MERS, which were the two pandemics which came with related viruses in the past. The natural infection, as I've told you, the antibodies are not developing. We don't know if there's in our cohort that we followed up, there are 10% who don't have any antibodies despite 6 weeks of being after the infection. 6% of them are actually developing infection antibodies as late as 3 months. And we don't know how long these antibodies will last. So that's not a nice picture. There is cellular immune response, we know that, but that is still in the experimental stage. The other thing is that vaccines to dengue have not been successful, which is a related virus. We might end up with vaccines where the infection, the immunity is so short that you need more than 2 shots in a year. So what is it that I or a person should want from vaccines? Of course, they have to be safe. And this pushing a vaccine just for the sake of political reasons is going to be a disaster. It has to be safe. It has to be immunogenic. As I said, it should have immunity which lasts worth its while. It should be looking at an outcome. You have to look at the outcome. Are you looking at prevention of infection, or are you looking at prevention of severity? Maybe there can be 2 different vaccines looking at 2 different outcomes. And well, there could be a mutating virus, so you might have to change the vaccine every year. We don't know that. And for me as a public health person, I would worry about how it's going to be scaled up. who is going to be prioritized for giving the vaccine? Are we going to take it ourselves, or are we going to give it to those people who genuinely need it? Where are we with the vaccines at the moment? Some positive messages have come. All of you have been reading in the newspapers. I'm not going to go into technical details, but 3 different types of candidates are being used. Either people are using a inactive virus. The Indian vaccine, which is being evaluated by Bharat is the whole inactivated virus. The problem with that can be that the immunity may not be long lasting. There are the Oxford vaccine is an attenuated, it's a virus where they're using, it's a vaccine where they're using another vector. They're using another virus, adenovirus, which causes problems in chimpanzees. And they're adding some proteins of this virus trying to induce an immune response. There's another one which is using adenovirus, which is used, which has caused problems in humans. So there are different strategies being used. These trials have all reached some of them are in phase. So actually there are 8 in clinical trials. There are 180 candidates already out there. So people have really moved fast. But which of this vaccine will work? We don't know yet. It's very early. Maybe we don't need one vaccine, maybe we need several vaccines. We also have to see how soon can they be escalated. Now, something like which the US is doing, the Moderna vaccine, is a vaccine where they're using a mRNA code. Now that is, it has problems of stability, but can be manufactured very fast. So, you know, it's in that stage just now, and we don't know which vaccine will succeed. And therefore, at the moment, we have to continue with all these experiments. Now, I'm just going to take a couple of more minutes on the herd immunity that Gibi spoke about. Please do not believe that herd immunity is round the corner. Do not believe that if you get the infection, you're going to be saved and you're going to develop the antibodies, you have the protection, and it's not going to happen that way. There's still a long way to go. We need to have at least 70% of our population to have the antibodies or the immune protection, which can protect those who do not have, who can protect those who get infected. So if you have 10 people with the infection or who've had the infection and are protected, that one person in that would be saved. So that is the kind of herd immunity required for being able to protect us. And Gibi was right. The pandemic is, I don't want to sound demotivating. I don't want to sound negative, but this is the reality. So just let me summarize this. The diagnostic testing, I know there were some questions on the chat box, which I'm happy to take up. Please be very specific about your diagnostic testing. Test, because you need to test, you need to isolate, and that's the only way of containing this epidemic. And increased testing is what we should have started long time back. Unfortunately, we didn't, and therefore that's been a problem. So test, isolation. I know there's a question about what happens if it comes in the family. I'll talk about it. We've gone through a whole household of COVID. All of us got it. The immune responses are still, there are many gray zones. We don't know the answers, and vaccines are still not around the corner. So what does it leave us with? It actually leaves us with the responsibility, and I don't tire of saying it. It's our responsibility to protect ourselves. Masks, social distancing, and hand hygiene. Now, hand hygiene is fine. I'm sure all of you will be doing. Social distancing is something which people shy away from because they feel, oh, it just means 10 minutes of taking the mask down and eating together, drinking together. It really doesn't work. The best protection is when both people are wearing a mask and you're at least 6 feet apart, and that won't happen if you eat and drink together. So do remember, at the end of it, all this immunotherapy, vaccines, antibodies are just going to be supportive and complementary to the public health vigilance. At the end, it is the public health preparedness that we have to do. And that I honestly feel, I mean, I'm sorry for going on and on. I honestly feel it rests with each one of us. You know, we can't, the government is doing fair amount, but I think we need to meet them 50% to be responsible enough to take these precautions. And there are many who are not. So I think I'll stop with that. And I will be happy to take questions after Garima is finished.
Shinjini, before you go off and hand over to Garima, could you just for a couple of minutes also talk about your personal experience that you've recently been through? And then we'll hand over to Garima, please.
Okay, so Videsh is also on the call, and you know, we are a big household because at the moment we're 3 generations living together, and we tested. So I just want to give you how we followed the protocol, and it may help some people who've asked this question. Our first member who was symptomatic was our daughter-in-law, who, mind you, has not been going out, and so that's community transmission for you. And that community transmission happened. She got symptomatic, but we tested her on day 4 or 5. I didn't test her right in the beginning because I wanted to be sure that we are not missing a COVID positive. She tested positive. We, of course, used the RT-PCR test. When she tested positive, my immediate worry was for my 94-year-old father, who lives, we live together. And I know Viresh is not going to like that. And for Viresh, because I mean, even though I'm a senior citizen, there are some, you know, comorbidities, and so we tested the next day. And as I told you, only Viresh tested positive. All of us tested negative. So we had tested early. Viresh must have had the infection, and so he tested positive. And then we tested 8 days later of our last contact with Viresh, which was a week later, and we all tested positive. So if we had tested earlier, we may have tested negative when we still had when we would have had the COVID infection. So that's the kind of protocol that one should follow for if you have a COVID infection at home. And that's now in terms of, once we had that, we of course isolated. Everybody was isolated in a separate room. I can't thank God enough for having and that's a question there. What do you do when you don't have enough rooms? Huge challenge. Despite us being able to isolate in every room, even though we were negative for that 1 week, we were isolated completely. And of course, there was somebody who I had to monitor the kitchen and all with my son, but each one got their food in their room because our house help was also admitted with COVID, and we all wore masks inside the house, and all wore N95 masks, because that is what brought down the virus multiplication. So remember, it's the inoculum of the virus that you get is also important. And we managed to, I think we managed to bring it down because we were all wearing a mask within the house, even though we were isolated. Then of course, we were started on some medication. I can talk about that later. I know there's a question on the chat box, how do you treat COVID? Vishu, I'll answer that later. And then we went on to test ourselves. We were monitoring every 2 hourly our oxygen, our pulse, our fever, and for any other sign which could have created, remember that don't believe that it can be asymptomatic and mild in everybody. There are huge issues. It just takes a few hours to escalate. The inflammatory stage comes on within a few hours, and that's what we need to worry about. So there's a viremia stage and there's an inflammatory stage. And when that inflammatory stage sets in, then you can have problems in the heart, kidney, liver, and that's what you need to worry about. And that is what you have to monitor for. And then, of course, fortunately for us, we continued to be okay. There were problems of minor symptoms, which I think we could live with. And we all tested negative. We needn't have got our test done, but we all enrolled in the study that we are doing, so we could get our testing done again, and we had our antibodies done. And none of us have antibodies. Not one of us have antibodies 3 weeks after testing positive. So that's where we are with a family getting infected. As I said, mask, distancing even within the house, and we had to wash our hands at least 2 to 3 hours and sanitize our hands every 2 to 3 hours to keep the level of infection low. So Rano, I mean, that's very quickly in a summary.
Let's invite Garima. Garima, are you there?
Yeah, I'm there. Thank
Okay.
you so much. I think we're having a very interesting conversation, so I'll keep my comments much smaller time frame so that more questions can be asked because they're more relevant in a day-to-day COVID situation. So quickly, when we are looking at COVID-19, a very different aspect from the from a personal point of view is that of the first responders. So I will quickly touch upon how it happened initially, what was the response that we had to make, and in future, what can we expect in the next 6 to 8 months to maybe a year. So quickly, the most important thing as first responders that faced the police, whether it was NYPD here in New York, because US was one, Europe and US were one of the first state, and after China. And New York emerged as one of the earliest epicenters after Italy in terms of COVID deaths as well as infections. So the response of NYPD, like all other forces, in the first response was that besides the criminal situation that they faced, they suddenly had a plethora of spike in calls of people who were panicked at the same time. They did not know, nobody could help them. So the most interesting part was that they asked all support, psychological, sociological, COVID, in the first month, say March, beginning to March end, which were not related to COVID, but anything that came in became a COVID situation. So you can imagine the spike which the control room of the NYPD must have faced. So what was the response of the police? Suddenly also the testing, as you know, all across the world was very limited. So was in New York. I had a cold at that time. And when my boss told me, Garima, please go into quarantine. So as of end of February, I stopped going to office. I started working from home. And I went to the nearest urgent care place because they told me, don't go to the emergency of a hospital. You will only clog and stand in the line. So I went to the nearest urgent care. They said that it's only the NY hospitals which are doing, and they are only testing very critical patients because they cannot test more than 500 people in a day. So you will be taking up very critical PPE material and testing kits, which we cannot afford. So madam, please go home. And if you are critical, and by critical means that when you are having breathing issues, only then come to the hospital. So that was New York for you at that time when we are talking March, April. And then of course you all know the spike and you must have followed how it was. The most important part was that while this was ongoing, the police had to deal with subsequent responses in regards to the lockdowns that happened in New York, because when people started losing their jobs and then subsequent underlying issues, social issues started coming in and the factors were not looked into with regards to other issues. One of the issues, as you know, which happened during the COVID-19 in the US was the George Floyd killing, which led to huge subsequent protests when COVID was at its peak. And that is the time when you saw that NYPD, almost 20% of the NYPD tested positive for COVID, and they had almost one fatality a week for the next 2 months. And that was because of COVID. Now that situation was in a city where you have, which is the richest city in the world, which apparently has the best medical facilities in the world, where everybody with big issues, medical issues, come for research and for other things. And this was the state of affairs in New York. The other aspect was that suddenly they were asked to do things which were outside the police domain and about which they did not know anything. And that was after NYPD had a lot of inputs from the CDC, that is uh, the CDC, which is the Communicable Disease Center control for the whole of the country. And that was despite that, and despite the fact that they have enormous, humongous resources. Now I come to the Indian situation where the police response was there. In India, we had the strictest lockdown, which was done. Unfortunately, the conditions in India were very different from US. It was not taken into consideration. And that is my view. I think were not taken into consideration when we were talking about COVID. Firstly, the lockdown in Indian conditions was, I think, a little premature in the sense that we did not do a proper analysis, knowing fully well what was happening around the world, that we had a social situation where we had a huge base, almost 70% of the people who were earning their livelihood day to day, like the migrant workers, which were so splashed across the media. Now, in this situation, the police was not geared, the system was not geared to tackle COVID. And while there were some communities and some issues that were brought up by the media that they were exponential in feeding COVID, but that was actually not the case. The case was that you had a huge amount of people who had to die either because of COVID or fall sick because of COVID, or fall sick because they just did not have the money to feed their family and they had to work. And they were asked to stay put in areas where they were. I think that was a strategic issue that the police was not geared to tackle. And then while they were tackling that, there were other social issues which were already inflamed. So these were some of the responses. And today, as I know, this data is not verified. Right now in India, a huge number of police officers are tested positive for COVID because they are dealing without proper PPE, they are dealing without protocol, and they are also dealing with lack of knowledge with issues. Now, what does that say for the future? I think, as Srinjari Mami and others have said, that in the next, in the foreseeable future for the next couple of years, we will be looking at sporadic lockdowns, curfews, work from home, social distancing. Economy going kaput and people being unemployed. So obviously the assessment is that we will have more social protests, they will rise. And as people learn to accept COVID, the crime graph which went down is going to come up. And the stretch on the police forces across the world, NYPD was working 12 to 14 hours. In India, Delhi police, Bombay police have been working up to 16 hours every day. So what is the stress on work stress, personal stress, domestic violence? We saw a peak in US, and I think we might end up seeing a peak in India. So these are some of the thoughts that I wanted to share. And the last word is that if the citizens want their police to work well, they have to cooperate with the guidelines and with the social distancing norms, as everybody has been stressing. That's all. Thank you.
Can I, Mr. Veera, before I hand over to you, can I ask Alok Sheel to speak for a minute or two? Alok, if you're there. Alok has done a lot of articles on COVID, and he's worked on a lot of numbers and forecasts and so on. Alok, are you there?
Thank you, Ranu. I won't take more than a minute or two because, I've only looked at the mortality data over time, the global mortality data, whereas the discussion we had is much more interesting and relevant. Well, if you look at the COVID data, you see that and I've looked really at the mortality data. on the assumption that it's difficult to compare across countries because the levels of testings are very different. So if you look at what is the level of incidence in different countries relative to each other, it becomes very difficult. Whereas the mortality data, flawed as it is if you take this as a single measure, perhaps it's the easiest to compare. So what is, initially the pandemic began, of course, in China. And then from there, it spread to Europe. So at that point in time, in the early stages, it seemed that, it's basically, the thing is spreading to a region of around 30 degrees north, and the countries below that, the incidence was very low. But that quickly changed. And it's then the alignment, the spread of COVID mortality, it moved more from east to west. In China, they controlled it very fast. I do not know what, the Chinese data is that they had a big spike and suddenly the numbers have dropped and there has been no single case, no single mortality over the last 3-4 months. Now, I do not know how that is the case, but neither does one hear that, that there's a large number of, mortality in China. But then most of the cases then were in, I would say, the transatlantic area, that is on both sides of the Atlantic Ocean, largely Europe and the Atlantic, if you include the Mediterranean system as part of the Atlantic. So, you have countries adjoining Europe, also near the Mediterranean. And now if you look at the COVID deaths, 54% are in the Americas, North and South America. Now they have about 12-13% of the global population, and they're 54% of COVID deaths. And if you include, the eastern border of the Atlantic and the Mediterranean, you have about 80% of the deaths accounted for by 25% of the population. And in Asia as a whole, it's about, including, the deaths in China, about 10% of the deaths are in the, the Asian region. That is if you exclude West Asia. I'm talking about largely East Asia and South Asia. And India's performance relative to its neighbors has been very disappointing. Its deaths per million are almost, much higher than even Bangladesh and Pakistan. I do not know why this should be the case. And the other worrying thing is that I've been looking at the data 6 weeks at a time, that, what has been the mortality growth. And you see that over time, the rate of mortality growth has been declining practically across the board. The decline in Europe was quite rapid. In about, initially, it really spiked, the COVID deaths. But in 4.5 months, the rate was down to less than 10%, every six weekly growth. And now it is less than 3% if you exclude Russia. Now, outside Europe, the decline has been much slower. And the real outlier in this is the United States. I do not know why that should have happened. Europe, you can imagine that they learned and they have a good medical infrastructure. They have a scientific temper, and they were quickly able to learn and bring down their mortality. But all those things, the US has also those things going. But if you look at the reduction in mortality has been much more modest. In fact, over the last 6 weeks, US is one of the 4 major countries where the mortality growth has actually increased. In India, it has reduced, but still it is, by globally I've seen it is among the major countries, I think about the 4th highest. In the last 6 weeks, mortality growth was around 150%. The preceding 6 weeks, it was about 330%. And there is an now, if you make these, simple back of the envelope calculations, if this rate of reduction continues, then by, January end, you should be able to contain, COVID mortality in India to under 200,000. But then you have certain models, you have this IHME, what they call think tank in Washington, DC, and they are making pretty apocalyptic predictions about likely mortality in India. They're saying that by early January, it could go up to, over 600,000, which would exceed that of the US. But the data I've looked at, does not seem, I think these numbers look a bit apocalyptic, but then, I've just looked at the data, the experts here will be in a better position to be able to interpret these numbers. That's all I have to say, really. Ranu, back over to you.
Thank you, Alok. That was wonderful. Suvira, would you like to take over, please, with some questions that might not have been answered so far?
Yes, Ranu Chacha. Send Chand away from here. He does backseat driving all the time. There are lots of questions which have already been answered, but I'll just put them in perspective because some people may not be following the chat. Both Namita and Madhu have asked about an SOP or a standard operating procedure for home quarantine, which has been answered and in quite some detail by Shinjini. Vaishali has asked about supplements like vitamin and zinc, and Stuti has asked for desi supplements, the Indian ones, and wanted to know, both of them want to know whether these are useful in combating COVID, and both Giri and Shinjini have said that there is no proof whatsoever that these things are good. Vishu Chacha wants to know, I'll read out his question. Can you explain what is viral load and what are the ranges? Low, moderate, high? What are the thresholds? So Shinjini or...
So, see, when we say CT titers, it indicates that there's a virus load in your nasopharynx and the nasal area. Normally, anything between 30 to 40 would indicate a low viral load. These are just arbitrary cutoffs. There are no studies which have been done which have shown that those who have 30 to 40 will always have a low infection. That's why I said that is just at this point, it's a cutoff that one uses for a positivity, for a positive test. There has been some talk now that whether you should reduce it to 35 and not make it 40, because maybe 35 to 40 are a lot of those asymptomatics, but you cannot go with that because there is no hard proof evidence on that in that area. So 30 to 40 would be what we call the low. 20, anything less than 30 and up to 20 would what one may want to say is moderate. And less than 20 could be what you have a really high viral load. But having said that, we've seen a lot of asymptomatic shedders where the CT titers, CT values are 20, 22, 23. So it really just means there's a viral load, which may be less or more, but whether that translates into the clinical symptom in an equal proportion is not very clear yet. So we've had patients who've reached the ICU with a CT titer of even 28 or 29. So it's the reason why I said you should be careful is a lot of labs don't give this CT titers. The CT titers are good to know. That means you have the infection. Now then let the doctor take over from there. Don't try to treat yourself with the CT titers because it's really, there is no direct relationship there.
Thanks.
Does that help?
Thanks, Shinjini.
Yeah, there's a question from Chand.
No, can I also intervene at this point?
Please.
What Shinjini is saying is absolutely correct, but at the same time, we must also understand that much of the symptoms of the COVID 19 is not because of the viral load, which is because of the level of inflammation which happens because of the virus. And at the moment, I don't think they have discovered a correlation between the viral load and the level of inflammation which might occur. Am I right, Chinjini?
Yeah. So I just answered this while Viresh is talking, while brought this up, because somebody asked the range of infections. I think Namita asked. I just want to tell the family that you can be lucky and be asymptomatic. You can be lucky and be mild to moderate. But, you know, there is that for people who get COVID, it's very important to watch out for that window, because if the inflammation sets in, then it takes, so there's a viremia where the virus is circulating in the body, and it can cause myalgia, it can cause fever, it can cause some of those symptoms. But when the inflammation sets in, that's when, you know, the problems start of the, you know, so that is the problems of the kidney getting affected, the liver getting affected, the heart getting affected. And if there's a respiratory symptom with inflammation, that's when you start getting those white COVID patches in the lung. And that is quite a disaster, because that's when your need for oxygen really goes up. And so one has to be very, very careful.
You could also tell them about the cytokine storm.
Yeah, okay. So somebody, I know, as someone said, this session should have been longer because there are many more questions, but there's something which I think we need to understand, that this whole disease is about, so it's a viremia, which then causes a change in the blood vessels. So the vessels become leaky. So there's a vasculitis happening. And this could be because of the inflammation. Now, there is something which is called a dysregulated immune response, where suddenly on the 10th day, this is happening in the second week of the illness. And that is why one has to be really careful. Second week of the illness, when whoomp, you may have this inflammatory reaction, and you can, what is called the cytokine storm. And that, if you survive it, great. If you don't, then you have problems of, you know, and that's a time when you have to take into consideration dexamethasone, you know, the other drugs. Somebody asked, what is the treatment of COVID? Look, that's a huge separate, it'll take me some time to talk about what the COVID treatment is, but if there is time, I can talk about it towards the end. So there is something called a cytokine storm, and therefore the request is that if somebody, God forbid, gets COVID, also let me tell you, all of us will get COVID at some stage. So it's going to happen, but we just have to be prepared to deal with it, like Givi said right in the beginning. And in that case, monitoring, intense monitoring, reaching the hospital early testing is absolutely critical.
There's a related question from Chan, which says, can it be said that the threat will recede when we have achieved herd immunity at, say, 50 to 60% of the population?
No. Also, but herd immunity is at least 70%. At least 70% of, like I said.
You shout a lot.
Another thing is, you have to have what is called an R0 factor in the newspapers. There's an R0, which means that how many infections can one person, how many people can, how much can I infect another person? How many people can I infect? And when that R0 comes down, that's the time when herd immunity is actually setting in. Just now we are way high. So herd immunity for something. So don't believe people when they say herd immunity there, and please go out and get the infection. It's not happening, not for some time.
There's a question from Arjun, which says, is it only a function of population density and indiscipline in India that's causing the inflated numbers? Because countries like UK, Italy, Spain, who were initial leaders, appear to have partially addressed the pandemic. And another related question from Sid from Melbourne. Just a minute, please. Has India reached its peak, or are we going to continue to first a bit longer?
Is Givi there? Givi, you want to answer that?
Yeah, I'm here, Mami. I just want to address those. Am I audible?
Yes, yes.
Okay. So they sound very good, but the biggest issue with numbers is that they are numbers, but is increasing by 80,000, and obviously if I get COVID today, and if I'm dying the same day, I will die only 4-5 days, or after a period. So the death will show up only then.
But I would agree with.
Yeah, Shinjini, please carry on.
No, I said I would agree with Arjun.
Whereas the
Sorry.
Hello.
Yeah. Go ahead,
Yeah.
Gibi. Go ahead.
So all these rates, I was just saying that all these rates, while they are good indicators, please don't take them on a daily living basis. There are two different aspects. One is the disease aspect. The disease aspect is, as Shinjini Mami has beautifully pointed out, the only thing that you need to do is keep yourself safe. There is no herd immunity which is coming to save you. Medicines, we don't quite know what's happening. And as far as the other question, I just forgot, Arjun asked about
density and indiscipline in the Indian population.
Yeah, I mean I'm working on the ground here. It's a fond hope that we have that there'll be discipline in the Indian population. You're talking about people over here who drive without a helmet, 3 people on a bike. They are more likely to die of falling down rather than of COVID. So to now expect this kind of population to have a social discipline of maintaining distance and all is going to be quite a task. And before, I think my connection is coming and going. So one thing I would like to point out, because it's a family group, that your hospitals, all your healthcare providers are right now overwhelmed with the load of the COVID diseases. So what you need to watch out for is to take care of your non-COVID health problems. If today these are not the times where you can simply go to a doctor with a high sugar and he will be able to take care of it the way it used to be. For all you know, your doctor may have been put on COVID duties and you may not actually be able to approach him. So what you need to be really careful about is taking care of your non-COVID problems at home. You should not be falling down unnecessarily. You should not be getting any other infection unnecessarily. If you are a diabetic, you should be strict about your sugar control. If you are a hypertensive, you should be really strict about your BP control. Because in these situations, on the ground, all hospitals are literally full to their brim. And for all these other things where, initially there was a response where Italy seemed to have improved, Spain seemed to have improved, all the lady leaders were being applauded. While it was very good, but you just have to give it time. One thing which I feel Mami might be more apropos to add more light to this. This is a disease which we did not even know existed before November 2019. So we are still learning about it. We are still learning about the patterns that it will give us. And only once it has played out its part in our and its own journey, we will probably realize where we are headed. So to summarize my part of it, the best scenario that I can see from working on ground and from whatever we can perceive, the best scenario would probably be that this will go on at this intensity for another maybe a couple of years or something, and gradually it will become one of the diseases that we deal with. The main problem of this disease of a seriously high infectivity, which leads to a huge load on your hospital environment, that would have receded, and then COVID will be just like any other disease. This is the best case scenario that I see. So I think that I don't know whether I answered the question, but these are the two things that I really wanted people to be aware of, that please take care of your non-COVID problems.
Yeah. Thanks, Gibi. Thank you so much.
Yeah. There's a question.
Bhabi, can I ask a quick question of Jivi on this?
Yes, Vaishali, please.
Okay, thank you so much. So then things like vitamin C and zinc, which help build your immunity, is that like a good thing? I mean, has it been proven that it helps you build your immunity and therefore you should, I mean, I've met people who say, okay, they're taking...
Vaishali, can I come in there? I know, let me come in there quickly because I know we're running out of time. And I think I'll just very quickly, Givi allows me, I will do what the management issue is today. We do not know whether they work. Let people say what they do. Look, if you have to go by scientific evidence, there's only evidence for two things. One is remdesivir, given to patients with moderate to severe disease, given at the right time. You just can't give everybody remdesivir. That is one antiviral. The other evidence is for dexamethasone, given to those who have inflammatory conditions like I talked about. All prophylactic medication is all people's observations, personal choices, industry driven. The industry is having a field day with a lot of zinc and vitamin C being, who knows? We don't know. Zinc and vitamin C are micronutrients which do boost immunity, but whether they work in COVID, we don't know. So they may not harm, but giving zinc to 100 milligram per day may not be the answer. So all I'm trying to say is that there is no evidence, really no evidence. You want to take it, sure, go ahead. It's not going to harm you that way. But whether it will work as a prevention, don't think you're prevented from getting COVID because you're taking zinc, vitamin C, any of the home remedies. In fact, the hydroxychloroquine story, I don't want to talk about it, but there is no evidence that hydroxychloroquine or ivermectin work as prophylactic medication. So today,
let me get in some more questions so that we can wind up, please. There are two questions, one from me and one from Gauri. My question is, initially there was a huge emphasis on infection from touching surfaces, not so now. Gauri's question is talking about washing groceries, etc., etc. Now, Viresh Bhaiya has replied to Gauri saying that you have to wash, wash, wash. What about touching surfaces? What about our grocery, cleaning, etc.?
Bhabi, can I come in on
that?
that?
Please. Yeah.
Right now, as Shinjini Mami has very beautifully said that, the evidence part, and I would just want to add to that Vaishali Jiji, vitamin C and zinc are as protective as Hanuman Chalisa. So you can chant that or you can take vitamin C. It is, as far as evidence is concerned, both are equal. But but as far as this washing and this is the washing utensils, the whatever comes in contact with you. See, we don't have any information about the definitiveness on how long is this virus viable on surfaces. Initially, it was said that it can last for 10 days, for 12 days, then for 14 days. On copper, it can be for 10 days. On magnesium, it can be for ages. So again, the problem comes down to the same, we don't know. Since we don't know, the only thing that we can do is be careful. And I don't see what is the problem in washing or, the problem in being careful with whatever groceries you are getting. If you're washing your hands after touching everything, these are very small prices to pay. I am working in a hospital, which is literally a COVID hospital. It is impossible to get any kind of treatment for non-COVID thing, and it is virtually impossible to get a bed in just for, if God forbid, if you are positive and you need a bed. So right now, any inconvenience is just not, it's not inconvenient enough to get an infection. So if washing your vegetables, washing your hands, washing your maid, washing your servant, anything works, please do that. Do not take it as an inconvenience.
And I want to add this, Suvira, I want to add there quickly that we were a paranoid family in terms of prevention. Given that my father is 94 years old and there's comorbidity with people, we still got it, despite all the protection that we could have taken. So it's as infective as that. And
there's a question on N95.
No, sorry, before that. while we are still at the washing stage. I think washing hands is not just enough. I think washing yourself is also good enough. So every time, for at least for people like us who go to work and go to the hospital and things, both Shinjini and I, when we get back from home, we actually have a bath. And we keep our clothes outside. We don't wear them again till they are washed and dried in the sun. So that's something which I don't know whether it works or not, but this is something which we practice.
Suvina, can I come in for a minute, please?
Yes, please.
Would we have the last two questions? Because I would like all the speakers who have spoken to have a small statement at the end of it, okay? Yeah.
So, most of the questions which have been asked have been answered, but there are two which I think are relevant for all of us. One is about, we've all been told, or we hear that the N95 mask is not such a safe mask for ordinary folks like us. A question from Vaishali. And there's a related question from Vishu Chacha about reusing of N95 masks.
So Bharbi, can I come in on that?
Yeah, please.
Yeah, so N95 is a mask which is actually meant for a healthcare worker. For a general population, for everybody else, a normal cloth mask would suffice. Now, there are two things which a mask does. A, if you are infected, it does not allow your infection to go to anybody else. And if somebody else is infected, to some extent, it prevents your droplet from going out. That is the purpose of a mask. In an N95 mask, the filters are more, etc., etc. I won't get into that. But use a mask, even a cloth mask is fine, as long as it does not have that funny round respirator attached to it. Am I audible?
Yes.
What's wrong with the respirator?
Sorry? I'm sorry, I could not get that.
I said, what's wrong with the respirator?
No, not the respirator. If you're talking about the medical grade respirator, that's a different thing. That's the mask in which people look like aliens. Not that one.
No, the regular mask with the two holes, black things on the side.
Masks are now coming with a small nozzle on the side. There is a small
Because
valve on the side.
Yeah, you can exhale out. If you're a positive, you will be exhaling out the virus, which is not good. And therefore, they are not recommending that.
Got it. Thank you.
So as long as you have a cloth mask, it should be fine. Don't worry if it is N95 or not. But have a mask.
But it should
if
be
it
a
is N95.
Yeah, but Givi, just tell them it should be a 3-layered cloth mask.
Yeah, it should be a 3-layered mask. I totally taken, Mami. It should be a 3-layered mask. And don't get worried about an N95 mask. If you don't have it, don't worry about it. An N95 mask is more for a healthcare worker in a healthcare setting.
Long flights, Givi, sorry, long flights.
Sorry?
Long flights. Long flights. Can we wear N95, but that's even more dangerous?
I don't. How long? I mean, you mean transatlantic 14-hour flights?
Yep.
Probably better to wear an N95 mask. Probably better. You will be in a confined space. You will probably be more exposed to other people's, secretions, aerosols, etc. Not a bad idea, but yes, if you are going to take that mask off on a flight like this, I would suggest going to the bathroom, take it off, breathe for a while, come back when you put it on again.
As long as there's no aerosol transmission in the bathroom. We don't know.
That's we don't know. So maybe wait for a while and see when nobody's been to the bathroom for the past couple of hours.
Shinjini, you can tell Shantanu Bhaiya about the Russian vaccine privately.
Okay.
Something going with Putin, who knows?
I would worry about it. I'm not to be quoted.
Okay. And I think there are a few questions to you, Alok, about Africa, but I think let's wind up. Gogi, I think you've received your answer. So there are lots of related questions, Ranu Chacha, but I think we should end. So I hand it back to you. Thank you.
Right. This was a wonderful, wonderful session. But I would like, before we close it, for each of the 3 speakers who are already present to make a last closing brief remark, please, before we close this. So who wants to go first? Givi, you want to go first? I think he may have a bad signal. Shinjini, you want to go first?
You know, I just hope that we've not kind of depressed and demoralized people. That's, I mean, I'm getting on the chat that this really is worrisome. See, it is, let me be frank, it is a worrisome situation. It will continue to be a worrisome situation for some time because we don't have many answers. And therefore, all, as I said in the beginning, I think the bottom line is that while all these answers are being looked for, while we are trying to find out, I mean, well, the scientific community, the doctors and everybody and other people as well trying to find the answers, I think as individuals, each of us has a responsibility of protecting ourselves, looking after our health, but more so to the community. I think that if you step out without a mask, that is something that you are dishonoring the community. Because if you're stepping out for a mask or you're indulging in a social distancing, which is not meant to be, like parties and, you know, all that, again, can be avoided. I'm sorry, and this is, I have this very rigid feeling on this, that for the next few months, it's best avoided, because at the moment we're going through a crisis and it's not going to end very soon.
Ivy, would you like to come in?
This is also, sorry to interrupt, but this is also an argument which is being used for not starting schools. Because they say that if the children starts going to school and they pick up infections in school and carry that infection back home, they're going to infect their parents and their grandparents and everybody else.
Givy?
Yes. Yeah, I think I have lost the signal.
Okay. Garima?
Can you hear me, Ranu Mama?
Yeah, yes.
Yeah, go on. Hello, yes.
Oh, should I? Oh, I just had I think I heard Africa somewhere.
Yes.
Now in Africa, you know, except South Africa, it's very virulent. The mortality rate and even the progression from on a 6 weekly basis. But why it should be so low in Africa, I do not know, because you could perhaps take the view that, you know, there could be a genetic explanation for this. But then if you go to African Americans, you know, there the incidence is, I don't know, what I've heard is actually, you know, higher than the national average. So that seems a little bit of a puzzle, but the specialists here would be able to throw greater light on that.
It could be also because of the Ebola, but I mean, that's a different story. There is some evidence to that, but I mean, one doesn't really know whether that is responsible for it.
Garima, would you like to make the last remarks before Givy comes in, because I don't think he has signal at the moment.
Okay. So, I mean, I just like to make one last remark that as we are seeing first responder responses to our issues, it is always reinforcing what has already been said by others, that in order to help yourself, it is better if we do prevention rather than look at normal situations. And the more contained we are and more aware we are in following the prevention aspects, the more we help the first responders in addressing the issue of critical cases. So, just want to add the last line is that if you are safe yourself, you make your community and neighbors safe, and that's a regular police officer message. And the more you take care, the less you are spreading it to others or is taking it on. And that's all. Be safe. That's it.
Great. I think Givy is still off the network, so I'm going to conclude here. All I have to say is wow, wow, wow. What a session. This is much beyond my expectation, at least. I have learned a lot from Gen 3 people in the family and one Gen 4 person in the family. It just is the beginning of this whole exercise to learn from what is the wealth of information in our family. Thank you so much. to Givi, to Injini, to Garima, and to Radhika, who despite a medical emergency came in and spoke to us, and that was wonderful. Before we go, I would like to mention the next two sessions, which are going to be very, very exciting. On the 20th of this month, Dakshita is going to take over as lead, and that session will be on Ruar stories, right?
Hi, Ranu Mama. I'm sorry, I'm interrupting. I got my connection back.
Okay, go ahead. Go ahead, Giri. Go ahead.
Sorry, I'm so sorry. Since you asked, you wanted us to add one last thought. My last thought is that the family and all its members should be safe, and for that they need to maintain a social distance. They need to wear their masks, and they need to take care of their non-COVID problems. And whatever else is the information as regards to the death rate, etc., those are all epidemiologies. Those are all things for people to worry about. But on the ground, you need to be extremely careful. And just to add, I mean, COVID-19 dealt with this earlier. Hello, can I be heard?
Yes.
Yes.
Yeah. So just an example, I'm not trying to scare anybody, but the people who have dealt with coronaviruses earlier were veterinary people, people who used to deal with doctors, veterinary doctors. And if they would see a herd of chicken or pigs who were infected with COVID, you know what the treatment was? The treatment was to exterminate the whole herd. The treatment was to exterminate the whole lot. So this is not something that we can do, and thereby we need to be extremely careful. And I know Shinjini Mami also said the same thing. I hope I'm not scaring. I hope I'm not being disappointing. But the truth is that you need to be extremely careful. I'd like to thank everybody for tuning in, and thank you for giving me this opportunity.
Alok, you wanted to say something?
No, I had my say on Africa. Nothing more.
All right. So the next session will be the Kuruvar stories, which will be led by Dakshita, who's also listening in. And she will be choosing the other speakers who will speak on that session. And the session after that, which will be on the 4th of October, will be U-shaped or a V-shaped recovery of the economy. And this will be led by Madhu, and Alok Sheel will also be there. And maybe one or two others will also be there. So listen, thank you so much. And please tell everybody who was not on this session that you missed something fantastic. And the next time, please listen to Ranu. And join in.
We had 43 people today.
No, 43 people are the
3 windows.
Windows. There, I guess there was over 50 people today. Like in your window, there are 2 people. So and 50 people attending a family discussion group is absolutely spectacular. So please, on the Kurwar group, please tell the others who missed this that this was a great session, and they are lucky. Who's that? So thank you, everybody. It was wonderful. And let's join in again for the next session, which will be led by Dakshita. Sorry? Okay. I think time to say bye-bye, okay?
Yeah, thank you. Thank you so much.
Bye.
Thanks,
Thank you.
Ranu.
Bye-bye.
Bye. Bye, everybody. Thank you so much. Bye-bye. I didn't know.
तो सावरी राइस हैंडी नहीं आ रहा